And thank you everyone for attending. My name is Dr. Evan Massey. I shall be taking you through a discussion on poisoning or our approach to poisoning in the emergency department. Joining me will be my colleague, Dr. Jean Wanjema. Dr. Jean, are you there? All right, as soon as Jean joins us, we will have her in. So, poisoning is quite an interesting topic, and it is a topic that a lot of people, or a lot of doctors for that matter, find a little bit hectic, especially in the acute setting, seeing that most of the time you're the initial point of contact of this patient. And secondly, this patient is essentially hospital naive, so you do not have a history. Probably the history does not also is not forthcoming at that particular moment in time because of the acuteness of the setting, and all these factors essentially influence how sort of we approach or poisoning affects us in the emergency department or affects our thinking in the emergency department. So it's quite a hectic set of symptoms and set of diseases to treat. I'll start this presentation with this is a short case presentation, if you'd indulge me, of a 6-year-old female who presents to the emergency department with a 4-hour history of nausea and vomiting. The vomiters, of course, contains food content, and the patient complains of abdominal pain and difficulty in breathing. The patient also is salivating, and at some point was complaining about a headache and a blurry vision. The patient also has psychomotor agitation. So when you examine this patient, you find that the patient is dehydrated, has a wheeze, and then progressively during the examination or during their stay there, becomes unresponsive to stimuli. So the GCS drops and the respiratory distress worsens, and the patient develops questionable breathing, and the GCS drops to about 10 or 15. When you check the vitals, the patient's blood pressure is 80/60, the ratio is 32, and a high heart rate of around 48. So this would be the typical patient that you find in the emergency department. Jean, you're here? Hello, Jean?
Yes, hi, good evening. I'm right here.
Hi. Yeah, thank you for joining us. So this is the typical type of patient that you'll find in the emergency department. Comes in with innocuous symptoms, or at least things that do not really make sense, because this presentation could essentially mean anything. So the discussion today is will be essentially to assist us get a path of diagnostics and management for such patients, because clearly, there's no one thing that needs to be managed, and there are quite a lot of things that are going terribly wrong and need to be sorted out immediately. So, Jean, if I could ask, what would you do for such a patient when they come into the emergency department?
Okay. So, as with all things emergency medicine, we like to take a systematic approach towards the management that follows the ABCD. So in terms of the airway patent, there's a lot of salivation, so I'd want to suction that out. In terms of the breathing, cosmal breathing, in obvious respiratory distress, probably tachypnea of 32, so maybe some supplemental oxygen for that. In terms of their circulation, maybe supplement that as we move to D, as we do a what's it called? Blood sugar.
Yeah. So thank you very much, Jean. So, but at least I get the point that Jean is trying to do. So Jean is Dr. Jean went directly into the management of this particular patient, and it did not go into finding out what exactly it is that this patient had consumed, or any specific antidote for that matter, which is essentially what majority of us usually rush to. So what Dr. Jean said is essentially correct. So this is a patient who you'd start looking at systematically, and that is what that is the point that I wanted us to get today. So So clearly this is a poisoning patient or a patient who has been poisoned. So then what is poisoning, if you'd indulge me? So poisoning is an acute illness, of course, and it results as a result of exposure to different toxic substances or combination of toxic substances. And I'd like us to lay some emphasis on combination, because majority of our patients will not just have ingested or been exposed to one thing, but a variety of things. So that even muddies the field. Exposures can occur via recreational use, overdose, self-harm. There are myriad of ways that this could occur, including occupational and environmental exposures, which are becoming more and more common and occur mostly in countries where labor laws are not necessarily stringent, and including currently chemical and biological warfare, which is something that happens around the world quite a lot, though not in our setting. So what are the routes that a patient can essentially be poisoned? And one of essentially the regular routes, so through the skin, via inhalation, via ingestion or injection. So there's a gentleman called Lindsay Murray who described acute poisoning as a dynamic medical illness presenting as an acute, potentially life-threatening exacerbation of a chronic underlying psychosocial disorder. And I think that's quite a nice way to sum it up, because it is an acute process, yes, and that is life-threatening, yes, but then it never occurs in isolation. Most of the time it occurs as a result of an underlying psychosocial disorder. And this is also things that we need to note while we are approaching this patient. So poisoning essentially can occur as a result of so many things. So on the right-hand side of the screen, you'd see a bunch of things that you could get exposed to and essentially develop symptoms and can be life-threatening to you. So it is pointless to note all these things. It's actually quite cumbersome, and just that list is probably the type of list that makes doctors get tired. And so to avoid the whole of this chaotic list of substances or heterogeneous groups of substances which present in heterogeneous ways, it is imperative that we have a systematic approach, that we need to think about these patients in terms of a systematic approach as opposed to a specific toxin or poison. And so in regards to that, essentially there are systems that are available to help us do this. And they've come up with pillars of management of poisoning, and they're as noted there. So the first pillar is essentially decontamination and early resuscitation, which Dr. Jean essentially went through quite well in her in a case presentation, in the initial case presentation. So before you think about what the patient has consumed or what the patient might have consumed or exposed to, the first thing you need to think about is, does this patient need resuscitation? And two, does this patient need decontamination? Now, decontamination can be defined in two different ways. It could be essentially just getting rid of the toxins that are on top of the patient or the skin of the patient, or whatever you can visualize. And that is what you're talking about. You're talking about early decontamination. There are other decontamination methods that we shall speak about later in the presentation. Of course, the second thing you need to do is do a risk assessment, and that is to assess where your patient lies. Supportive and definitive management follows, and then early recognition of the psychosocial issues. Now, the last point is something that we miss a lot, because we look at a patient in an acute setting and forget that this presentation might be as a result of an underlying or a long-term psychosocial problem. So external decontamination is essentially an effort to minimize the contact and absorption of the toxin and protect the patient and staff from further absorption of the particular toxin. It's an effort to remove the patient from the toxin, but whenever we are doing it, we need to be careful not to essentially sink the patient into hypothermia. The methods of decontamination vary depending on the route of access or route of exposure. So for nasal poisoning, for example, what do you do for the patient? You remove the patient from that particular area. For swallowed poison, you do not make the patient vomit. That is contraindicated because of the risk of aspiration. But otherwise, if you see something that is in the mouth, just as you're taught in ACLS or TLS, you need to remove it out. In a conscious patient or an adult patient, if it is a toxin that has been put in the mouth, you're more than welcome to ask the patient to gargle some water, but spit and not swallow. In skin poisoning, of course, you need to wash it out. And it is critical that you wash the toxin out from the skin contact for about 15 minutes. Now, 15 minutes seems like a long time, but it's really not. But the caveat here is that you have to make sure that your patient does not get into hypothermia. In terms of poisons in the eye, which essentially occurs to a lot of us in our early years and even during our practice, it is important to essentially flush the poison out by washing with lukewarm water for 10 to 15 minutes. Ideally, that should be running water. So in terms of early resuscitation, Dr. Jean, would you please mind, because this is what you're talking about, would you mind just taking us through some of the components of early resuscitation of poisoning patients?
Okay, right. So like most of us can see on the screen, like I had said earlier, systematic approach to everything. You need to, and in cases of poisoning, you need to protect yourself as well before you try and help the patient. So PPEs are very important, especially when you're considering different types of contaminants. There are some that can easily seep through the skin. So you want to have the appropriate gloves, the appropriate gowns or plastic apron. You need to work as a team, so you need help with you. In terms of the airway, check, is the airway patent, are there secretions? Quick look at their GCS, because the lower it goes, the more you need to, and faster you need to get a secure, definitive airway. Vital signs are very important. What are your saturations? What's your respiratory rate? You want your patient not to tip into hypoxia. Like we all know, one of the H's and T's. Hypoxia is a big cause of cardiac arrest. If you're having trouble, if the patient's having trouble breathing on their own, you might want to consider more advanced ways of supporting their breathing, from as simple as a mask to a BVM to non-invasive ventilation, and appropriate ventilator modes if they are ventilated. Then in terms of their circulation, they can easily tip over into fluid overload or fluid insufficiency. So judicious use of fluids as needed and pressors if you're having really bad hypotension. Some drugs can cause arrhythmias, so you might need some antiarrhythmics in some situations, or even as you go down to disability, your GCS, your sugars as well. Keep the patient, as much as we decontaminate, most of the times we remove the clothes that they came with, which might be contaminated. So you want to keep them in warm, clean surroundings, so as not to tip them over into hypothermia.
Yeah, that is so good. Also hypoglycemia. Remember, when the patients come in, we just need to make sure that our glucose is the normal level. And the optimum level is essentially between 6 and 10. It's important to note that a glucose level of say 5, essentially you're teetering at the edge, and your margin of safety is quite low. So it's important to keep it around 6 to 10. Now, there are special considerations that we make for CPR. That is in case the patient codes during the initial evaluation, and the special considerations are that we need to prolong CPR in case of arrest, and 2, we need to institute extracorporeal life support measures early. So this is a patient who you should consider intubating. This is a patient you should consider putting dialysis catheters in. A patient you should consider putting central lines in, because you might require to put them on essentially pressors and all that. So then, of course, the supportive care that you give during the initial evaluation or your initial contact with the patient, and it's you need to control seizures. A lot of poisons present with seizures. a lot of poisoning, present with seizures, prevent hypoglycemia, hypothermia, which you talks about, or Dr. Jean talks about, and dysrhythmias. Now, remember the first part was the first thing you do is when you contact the patient is to decontaminate, or at least do the external decontamination of the patient. And then the second part is to do initial resuscitation, which Dr. Jean told us is essentially going through your A's, B, C, and D's. Now, the second part is to assess your risk. So risk assessment. It is a critical part of managing poisoning, and I tend to imagine is the second most important part after resuscitation, because resuscitation that will keep your patient alive. So if once you have succeeded in resuscitating the patient, or during the process of resuscitation in a well-staffed center, you should now start assessing what the risk of your patient is. This is where the bread and butter of poisoning is in terms of the knowledge, but not in terms of patient survival. Yes, both in terms of patient survival and the knowledge base in poisoning. So this resuscitation should be done early when the details are quite clear with everybody involved. So this is the part where you speak to the paramedic, part where you speak to the family and try to get all the details in deep detail and as explicit details as possible, so that you have the data from the very onset. And what data are we looking for? The data we're looking for is essentially what the presenting complaint of the patient is. So if the patient is moribund or comatose, you need to find that out from the people who have got the patient. Events surrounding the exposure. So where did they find the patient? The time of exposure, probably what time was the patient found, the amount of toxins ingested. So in case these toxins were found there, then it would be good of them to bring it, and you need to count and make sure you have all this data, because it becomes extremely important in terms of management. Then you also need to think about whether there are any co-injections, which, as I mentioned earlier, is quite an important part of management. And then you look at the family history and past medical and surgical history. So all this information is supposed to essentially lead you into two conclusions: to understand whether it is an intentional or accidental ingestion, and to also understand how serious it is. So is it low risk or is it trivial? Now, after you've gotten all this information, now let's get into the bread and butter, or at least what people tend to think about first, yet they're supposed to think about second when dealing with this patient. So, and these are the toxidromes. It is interesting that, so not interesting really, it has been made efficient that a lot of these poisons that I mentioned earlier, or the long list that we usually have, has been simplified based on the presentation. So when a patient or when somebody takes in a particular toxins, there's a particular set of symptoms that they present with. And this set of symptoms are essentially common among a particular set of poisons. And so this brings us to essentially toxidromes, which are important for us to know. So there are a number of toxidromes, and I'd like Dr. Jean to essentially take us through the first few, if she may.
Okay, so like you said, toxidromes, it's a constellation of signs and symptoms that are characteristic of specific drugs. So like in the chart that we can see there, start with the first, it's opioid toxidrome. So these are patients who maybe took an overdose of heroin or maybe a morphine overdose, especially our palliative care patients. So these patients tend to be very dry. And with the worsening of the more that the opioid they've ingested, they'll end up having coma, pinpoint pupils, respiratory depression, which is the biggest thing that is a red flag. It's the biggest red flag we have. They'll also present with hypotension, hyporeflexia, especially as their GCS keeps going down. Everything seems to be more depressed. Yeah, so that's the opioid toxidrome.
Yeah, so and then I'll just take us back. And just before we go deeper, we dive deep into that, I think it is important that we note that there's a way that toxidromes present, and typically the vital signs can be either depressed or elevated. So when you're going down this particular chart, there are a couple of things you check out. If you notice up here, you need to do your rapid stabilization and supportive care. And then just on your physical examination, of course, we look at the eye and you find out what exactly is happening with the eye. Yeah. So is it pinpoint or do you have dilated pupils? And then after that, you look at the skin, which is something that we probably have looked at this particular point. Is it dry or is it diaphoretic? Now, myotic pupils and the dry skin or diaphoretic skin, those are vital signs essentially that present as a result of opioids and sedative hypnotics and cholinergic toxidromes. Now, these are the typical toxidromes that cause depressed vital signs. I think that is something that you need to know. So a patient who comes with depressed vital signs, think your opioid, that Gina's mentioned, think your sedative hypnotics, think your cholinergics. Now, a patient who comes with elevated vital signs, think your hallucinogenics, think your anticholinergic, sympathomimetic. You could also think of a sedative withdrawal, or you can think of neuroleptic malignant syndrome and serotonin syndrome. So just before we go to the nitty-gritty of the initial toxidromes, I think it's important that we understand that. And those are the few things we look at. Now, Jean has mentioned something about opioid toxidromes. Let's just have a look at this particular baby. So we have a 2-year-old boy, and by the if you have or if you think you know the answers to these particular questions, just feel free to just type them on the chat. And we'll keep looking at your questions, of course, as they come in. So you have a 2-year-old boy who presents to the ED with injection of Suboxone. Suboxone is essentially a drug that is used for opioid use disorder. So essentially, this was a boy who came in drowsy, was brought in by the father, and the father said that he's been struggling with opiate addiction and has been on Suboxone. So according to the father, he turned back for a moment and the child grabbed some of the Suboxone and took it in while he wasn't looking. So the unaccounted for Suboxones are essentially 3 tablets, which the components are noted in the presentation. The child is drowsy, the child has painful pupils. You'll notice the blood pressure is reduced. The heart rate for a 2-year-old is also reduced, and the respirate is also reduced, but the SpO2 remains okay. So this is a typical presentation of a patient with an opioid toxidrome. So this child presents with the pinpoint pupil, presents in a coma, respiratory depression, hypertension, and hyperreflexia, as Dean mentioned earlier. Now, these are some of the easy toxidromes because they present with this particular set of symptoms, and it's easy for us to know what to manage it with. Dr. Dean also mentioned some of the medication that or some of the medicines or recreational or even hospital-used medication that cause this particular toxidrome. So your heroin users and people that use cocaine nowadays have it laced with some fentanyl, and so they might also present with an opioid toxidrome. So I think it's an important thing for us to notice when we are dealing with some of these patients. But thank you so much, Jim. Since we do not have so much time, we'll just go to the next toxidrome using a case. A 46-year-old male referred to a facility with a history of psychiatric illness, then ingested 50 mL of insecticide prior. In case you have an inkling what toxidrome we might be dealing with here, please just type it in the comment section. We'll have a look at it. And on examination, the patient has an ultrasensorium and has increased sweating and has a GCS of 11 over 15, sorry for the typo, and a blood pressure of 110 over 60. When you look at the respiratory system has crepitations. So a member of the audience called Marcy has mentioned what the answer is cholinergic toxidrome. Thank you very much, Marcy, that is correct. Now, how do cholinergic toxidrome present? Essentially, having a look at this picture, they present with pinpoint pupils. They're usually quite diaphoretic, and they have quite a lot of secretions rare lacrimation, emesis, and of course they're losing water, and so they'll probably also have urination and diarrhea. But with that, they also have a bradycardia. You'd expect that when they lose fluids, they have a tachycardia, but they have a bradycardia because it is a suppressing toxidrome. Now, cholinergics, for example, organophosphates, which one of the members of the audience called Simon has mentioned, essentially mimic our acetylcholine, a neurotransmitter that is found in the parasympathetic nervous system. The medications that cause this are carbamates, organophosphates, and remember I mentioned about exposure as a result of chemical warfare and war for that matter. One of the chemicals used for warfare is serine, which also causes similar symptoms. Patients essentially produce a lot of secretions, and the mechanism of this essentially they drown in their own secretions. So when managing these patients, as Jean, what are the special considerations that you would take?
So these are the patients that you definitely have to decontaminate in terms of their clothing, especially if it's a skin exposure, or even ingestion. Some of it could have spilled onto their clothes. After you do that, you go through your ABCs as well, ABCDEs. And as you come towards your E, you're thinking about your antidotes. And in this specific case, our antidote would be atropine.
Yes, perfect. That is a very good summary of what to do. Now, let's discuss about another patient. No, you mentioned atropine. Sorry, let's talk a little bit about atropine. So another question: while using atropine to treat organophosphate poisoning, so this said patient, all the following are endpoints of treatment, except which of the following? So is it resolution of the bradycardia that the patient had? Is it a patient having the pupils fully dilated? Yes, fully dilated. Is it drying of oral secretions or resolution of bronchospasms? So Vincent said B, PT said A, Anne said A. All those are very good tries. So everybody, yeah. So I think there's a sample of every answer that is on the screen. But then actually look at the question. So which of the following are all the following are endpoints except which one? So what is it that we're not looking for? Of course, you want our bronchospasms to stop, right? We want our oral mucosa to dry, because essentially that is what we've been managing all along. Now the question is, do we want bradycardia to resolve fully, or do we want to achieve full pupillary dilation? So I've narrowed it down to two. Yeah, and everybody's getting it now. So it's B. Yeah, achieving full pupillary dilation is not an endpoint for organophosphate poisoning. Leave the pupils alone. Look at your airway. Look at your breathing. Look at your circulation. Always remember, when you're dealing with a poisoning patient, those are the things that you need to sort out. Yeah. Very good job, everyone. So Jean, do you mind telling us a little bit about sympathomimetic toxidrome?
I think even just before we move on, I think another very pertinent question we should ask, guys: when should we give atropine for a patient who has suspected organophosphate poisoning? When do you guys think that should happen? Is it when you look at their pupils and they're constricted, or is it when they start having respiratory distress? What do we think? So yeah, Dorcas is right. When you start having your secretions are too much, and they're compromising your state. So that's when the atropine comes in. Good job, guys.
So, sorry, Jill. I think that also just takes us back to the whole concept of risk assessment. So you assess the risk of a patient and understand what is it that is this patient's life potentially in danger, and therefore should I take the action? Because you remember, even our antitoxins, they're not necessarily innocuous. Atropine, we know what the effects of atropine are on the body. So you just don't give it willy-nilly like candy. You have to be very specific about your indications. All right, Jean.
All right. So we're going to move on to sympathomimetic. So an easy way to remember this toxidrome is it mimics your fight or flight response. Yeah. So you have an increase in your adrenaline and norepinephrine, and your body is just racing. Yeah. So you'll have your tachycardia, You'll have a pressured speech, your dilated pupils, like you're just ready to go, ready to go, ready to go. So this will happen with stimulants and things like cocaine. They'll be triggering all your norep. You'll just be firing on all cylinders. And that's exactly what your patient will look like, yeah? They'll be anxious, grinding their teeth, they'll be sweating, their pressures will be quite high, tachycardic, pressured speech, things like that, reflexes, AWOL, and they'll be very hot, yeah.
Yeah, so that makes sense. So that's our sympathomimetic toxidrome. I'm sorry, we're not going to go into great details about this, but Jean has mentioned it quite well. And then we have our anticholinergic toxidrome, which is also quite another common toxidrome. Remember atropine. I just would like us to jump to the very bottom of the slide. Remember atropine that we're using to treat our cholinergic toxidrome. So it is here as a cause of an anticholinergic toxidrome. So this is just to emphasize the fact that whatever it is that we give, it's not an innocuous thing. And an overdose can actually tip you into another toxidrome while treating a different toxidrome. So anticholinergic toxidrome, essentially there's a nice mnemonic or a nice way to remember it. And it's just this dude over here who's supposedly blind as a bat. So essentially the patient has dilated pupils, mydriasis, and then cannot see. As a result, so they're blind as a bat. They're mad as a hatter because, they're crazy. They're quite confused. Then they're dry as bone. Remember, the other toxidrome patient was essentially producing too much secretions. This other, on the other hand, produces very little secretion and retains urine. Remember, the other one had incontinence and had diarrhea. This one has the exact opposite. So this patient would also be blind red as a beet. So they'll have flashing of the skin. How does this happen? This is because essentially the medication or the toxins that cause this particular toxidrome, they competitively block acetylcholine receptors at the muscarinic receptors. They have quite significant muscarinic effect, but minimal nicotinic effects, and that's why they present with these specific symptoms. Remember, our nicotinic effects, essentially weak muscles and stuff like that. And it is important that you remember that when you're managing this patient, the general body weakness that results from this toxidrome or whatever it is that they took is not really an endpoint of management. But you need to think about the things that would kill the patient. So examples of drugs that cause these particular toxidromes are, and the reason why this toxidrome is actually the most important, one of the most common toxidromes that are around is because the medication that cause this are medication that are easily found over the counter. So your antihistamines, antiemetics, antipsychotic, antispasmodics, motion sickness medication, muscle relaxants, and tricyclic antidepressants. So you remember your hyoscine, and your atropine for that matter. So it is also quite an important toxidrome to have a look at. Jean, something about sedative hypnotics?
Oh, also Buscopan is one of the things.
Yeah. So an overdose of Buscopan will present like this. But as much as we know that an overdose of Buscopan could present like this, what is the most important thing you need to know? Is that to keep this patient alive, you need to go to and I'll keep insisting this through the whole presentation. You need to go through your A, B, C, D. That is the only thing that you need to take care of, and think about this as a secondary issue. All right, good. Sedative hypnotics.
So as the name suggests, they're sedatives, right? The benzodiazepines, the tricyclic antidepressants, all those kind of drugs, the ones that keep you cool and mellow. If you take too much of that, you can end up in this toxidrome, sedative hypnotic toxidrome, where everything is just depressed. Someone looks somewhat drunk, yeah? Slurred speech, incoordinated, unsteady gait. Their reflexes are very slow and delayed and decreased. And at the very worst end, they could actually be comatose, right? So these are very key ones that you need to look out for, especially. And then a very important thing is if they're on benzodiazepines, you want to know, have they been on them for a long time, meaning months on end, or have they just used them for 2 days? Because the management is a bit different.
Yeah, that is actually quite important. During my reading about this, I noticed some studies have shown risk factors of essentially this particular toxidromes, sedative hypnotics, and it's actually quite interesting how race also plays a fact, gender plays a fact, and abuse of other medication, for example, alcohol, cigarette smoking, also plays a critical role in this.
Gender?
Yeah, in this toxidrome. So when these patients present, also think about this other thing. So probably think about chronic alcohol use and stuff like that. The hallucinogenics. Now these are the fun drugs, but they also present as patients get intoxicated with some of this, and look at this gentleman here. The common medications, LSD, ecstasy, mushrooms, cannabinoids, synthetic cannabinoids for that matter. The management for this is, of course, giving benzodiazepine, and the hallucinogenics, of course, they just cause you to have hallucinations. And this is the type of difficult patient you'll have in the emergency department. You'll be extremely paranoid. You go touch them, they think you're the devil and you're trying to do something. They have this demonic hallucinations. The hallucinations are usually quite bad. They're not just the regular hallucinations. They have a flair to them. They take them directly to hell. The patient will also present with, systemic problems such as myocardial infarctions and kidney injury. Yeah, so these are quite important toxins. And with the conversation about some of this medication, or the availability of them becoming easier, it is a toxidrome that is important for us to all know. The management, of course, is benzodiazepine, and you just need to calm the patient down and, as usual, manage your air, breathing, circulation. So we'll go a little bit faster because we're probably running out of time. And serotonin syndrome, of course, is a clinical diagnosis and is usually often fatal. It's one of the toxidromes, by the way, though it's quite a specific one. And the medication that causes them are mixed. And the examples are SSRIs, monoamine oxidase inhibitors, and tramadol. And these patients will present with a spectrum of symptoms. So if it's mild, they'll be sweating, they'll have fever, agitation, confusion, some diarrhea and tremors and poor coordination, sorry. On the other end of the spectrum, this patient will have hypothermia. That is one of the pathognomonic signs. They'll have hypothermia, they'll have seizures, comas, and deaths. Some may present essentially dead. And the other one, in regards to the muscles, is muscle rigidity. So remember, with increase in severity of poisoning, there's also increase in manifestation of the symptoms. So for example, your neuromuscular symptoms, you'll have tremors, and then later on you'll have hyperreflexia and clonus and myoclonus, and then later on you'll have rigidity. Remember, cryptoheptidine is our antidote here. Then the other one that also is almost a sister or cousin to serotonin syndrome is neuroleptic malignant syndrome, and it's triggered by antipsychotics and antiemetics, and the management is bromocriptine and benzodiazepines also, depending on what you have in your system. Now, we could go through all this, but it is important that you remember that on the emergency medicine or the casualty app, for that matter, which is available on Android and I think Apple, and also
coming to iOS near you soon.
Yeah, yeah, and also in multiple other sources out there, you'll find doses and protocols on administration of all these antidotes. Please do not be a superhero. Don't think you know the dose. Just go look, go refer, yeah? And that's for the betterment of your patient. So despite the fact that you've spoken about toxidromes, there are some other toxins that are quite common. And some of them are alcohol, and alcohol components, paracetamol, because it's quite readily available, kerosene and hydrocarbons, which is common especially among self-harm patients, and carbon monoxide, which is usually an accidental exposure type of situation. Now, for paracetamol, we will not belabor the point on presentation, but essentially this will be a patient that will present with your, tachypnea, your alkalosis earlier, and progressively also liver injury progressively as the toxin goes by. So for paracetamol injection, it's important that you note that it is quite important that you give the antidote, which is N-acetylcysteine, quite early. But there are also other modalities that you can manage it with. And one of them, especially if the injection was between 2 to 4 hours prior to presentation, can use an activated charcoal. And yes, it has been shown that there's 100% survival in patients who get N-acetylcysteine within 8 hours. So for your patients who have paracetamol intoxication, especially if it is above 150 milligrams per kg, so you just need to count. Remember the targeted history we talked about. You need to count and multiply and get the total amount of injection and treat appropriately. Jean, what do you think about alcohol poisoning?
Oh, alcohol. Yeah. So I think this is one of the things that's been coming up a lot more recently in the news. You hear about, actually the most recent was about 5 people died after an alcohol binge. They had some methanol poisoning. So it's quite common in our country, to be honest. So it's something very important that we all need to familiarize ourselves with. And in terms of this, there's the alcohol, meaning ethanol poisoning. And then there's the toxic alcohols, the likes of methanol, ethylene glycol, isopropyl, that will present a bit differently. Yeah. So for ethanol, most of it is supportive care, to be honest. But it will cause a lot of depression, like your rest rate will be depressed. You might end up becoming drowsy, comatose. You might get tachyarrhythmias and stuff. So these are those patients, a lot of supportive care, making sure the airway is okay, give them some fluids. If they're chronic alcoholics, you want to supplement with the likes of thiamine, or you just give them some Pabrinex. It has everything good for them. Yeah, make sure they're not hypoglycemic as well. So yeah.
Yeah. So in the chat section, I've seen one of our attendants ask what is serial GCS, which is something that we have was mentioned earlier in the slide. Serial GCS is essentially a short way of saying you need to reevaluate the patient's mental status periodically and quite a number of times. So you need to do it, say, every 10, 15 minutes. Because for some of these toxidromes or for some of these intoxications, the GCS can drop quite fast. And so you might, walk out of the room thinking you're going to sort out another patient, then you come back and you find you've lost the air of the patient. So just to answer that. That being said, of course, Jean has mentioned about ethanol, methanol, and ethylene glycol. Remember, ethylene glycol is found in sometimes hand sanitizers, and this is a poisoning, especially that during the COVID pandemic, we saw a lot of children come with, and so yes, it can also occur in that particular age group of people. Remember, some of the symptoms will be, blurry vision, scotomas, and flank pain as a result of kidney injury, hematuria, liguria. And when you do a blood gas, which is not a very available resource, but quite a useful resource, you'll find a higher number of metabolic acidosis, which is quite pathognomonic of, alcohol and ethylene glycol poisoning. Our antidote here is, of course, fomepizole, which is not readily available, but it has been mentioned also how we can use ethanol, which is your shots of vodka, to treat this particular condition. Now, always remember that look onto the protocols and make proper calculations of your ethanol dosing so that you do not end up killing the patient again with alcohol intoxication. And also keep it in your opioid closet so that it is not abused. Yeah. So those are the toxic alcohol, and we've talked about the antidotes. Jean, another thing that is quite not really common but quite interesting presentation is kerosene and hydrocarbon intoxication or poisoning. Do you mind taking us through it?
Absolutely. This is something that I've seen a lot, especially in our rural areas. We find that we've gone to get some kerosene and we've put it in a Sprite bottle. And then we have a toddler in the house who crawls around or runs around and they say, oh, Sprite, and take a nice gulp of it. Kumbe, they're ingesting some very nice kerosene there. So yeah, a lot are accidental ingestions, especially in children. But luckily, kerosene isn't too bad because it causes more of pneumonitis in the chest. So the child will be coughing, might have a bit of respiratory stress. If they do have respiratory stress, admit the child, put them on some oxygen. But otherwise, if the child is stable, just monitor them for a short while, reassure the parents, tell them to store the kerosene properly next time, and we'll be good. Yeah.
Lovely. So the mechanism is quite common, especially in the rural areas, and it's important that we know this. Yeah, you do X-rays and confirm that, but also the characteristic smell will be present, so it's quite easy to diagnose if you're careful. Now, you'll notice that we haven't spent too much time belaboring the point on the antidotes that are there, because this is information that you can always get through the apps and through your various resources. We will put more emphasis on supportive care as we head towards the end of this presentation. Now, decontamination, which is essentially one of the core elements of managing or poisoning, is essentially a mechanism through which you eliminate or remove the toxin from the patient's body. So forget about external decontamination, which is where you remove your clothes, you wash, and all that. Now, this is trying to remove the toxin from the patient's systems in the quickest and most efficient way possible. There are a couple of mechanisms. One is enhanced elimination, two, urine alkalization, and three, extracorporeal elimination, which involves essentially hemodialysis. The last one, which is for a very specific subset of poisoning, is exchange transfusion, which is quite useful in methemoglobinemia. These measures essentially constitute the supportive care of the patient. So after you manage the air, breathing, circulation, so your patient with not able to support the airway, you intubate, you've put them on ionotropes or whatever it is, the level of care that you needed to do. After you're done with that, you need to think about removing whatever toxin is there. So I'll just have a short conversation about enhanced elimination. And this is a technique to enhance removal from the body. And the indication is where you have severe toxicity, a poor response to supportive care or the antidote for that matter, that is if you've given it. And if the toxin that you're trying to remove has suitable pharmacokinetics for enhanced elimination. Remember, these things that we've ingested are chemicals, and we have to think about their chemical properties to enable us remove them out. And then you also need to think about the risk and benefit ratio for this particular patient. Sorry, I'll digress slightly. There's a participant who's asking about paracetamol poisoning. And yeah, we had a short conversation about it, but it's also quite a common toxidrome. And remember your N-acetylcysteine, and remember that it needs to be given as early as possible. And then remember, you need to do your paracetamol levels at 4 hours and after, because if you do them earlier, you don't have complete absorption. So Jafet, I hope that answers your question. This seems to be a burning one. Now, enhanced elimination, the major method that we use is using activated charcoal. So I'll start with a question, and I'm sure not many of us will be able to answer this. I wasn't able to answer this. So for multidose activated charcoal administration, it's indicated for the following toxicity. For which of the following toxicities? Is it sodium valproate toxicity, digoxin, lithium, or carbamazepine? Jean, do you know?
Yeah, I do. Actually, there's a mnemonic. Let's guess a little bit first, and then we see.
Yeah, I'm looking at the chat section.
Mm-hmm.
No one is willing to commit here.
Oh, Dorcas is there. She said carbamazepine.
Oh, yes. I'm sorry, I haven't seen that.
Oh.
Yeah. Well, but that's lovely. Dorcas, that is the correct answer. The answer is carbamazepine. Do you mind telling us about it?
Yeah, so there's a mnemonic for some drugs where multidose activated charcoal is indicated. So theophylline, phenobarbital, dapsone, carbamazepine, and quinine. Yeah, so these people drink charcoal quickly. So that's a mnemonic that's found in our EMKF algorithms. You can just download them on the website and you'll have it right at your fingertips. But yes, carbamazepine is one of the few that you give more doses of activated charcoal. Yep.
Perfect. So these people take activated charcoal. So these people take charcoal, sorry, that is it. Remember our dosage is essentially 50 milligrams for an adult and 25, and then after that, 25 milligrams every 2 hours. It should be given at about 6 hours, after which you should see improvement of symptoms. For children, giving children activated charcoal is quite difficult, and then there's a trick for this. So you go buy some ice cream and put activated charcoal in the ice cream, so it tastes nice, and then you give it to the child. And you can call it Batman ice cream if you want, and that will give them a psych to actually take it. And then the dosage is at 1 gram per kg. I remember activated charcoal essentially just works by using the gut or the gut mucosa as a dialysis tool. So it essentially creates a high concentration gradient in the gut and helps resorb the toxin back. Now it takes into consideration the pharmacokinetics of this particular toxin, because some cannot be sorted out like that. The complications of it are vomiting, aspiration, which is quite a bad one. And so in case you're losing your GCS, or in case you're not sure about your airway, you're better off intubating this patient before you give activated charcoal. Then the other one is, of course, charcoal bezoar and corneal abrasions. So all the following, another question, all the following are the complications of urine alkalization. Clearly, we're moving to the next one, which is urine alkalization, except which one of the following. So urine alkalization essentially means exactly that. You're trying to get the urine of the patient to become, to have an alkaline pH. And this essentially makes or turns the environment into an alkaline state and makes it easy, or the state of weak acids in an alkaline state is an ionized state, which makes it difficult for them to be absorbed back into the body. So that helps you eliminate a little bit faster. All these are complications of them. You can have alkalemia, but it's pretty much well tolerated. You can also have dehydration. Sorry, you can also have hypokalemia, sorry, because you're giving sodium, and you can also have hypocalcemia because you're giving sodium bicarbonate. But dehydration is really not one of them. And urine alkalization is recommended, especially for salicylate poisoning. So for your paracetamol and your phenobarbital. So, for your aspirin, sorry, and your phenobarbital, I'm sorry. So those are the things that you need to know about urine alkalization. The pH that you're trying to achieve would be 7.5, and then you're supposed to keep checking this. So you can do this using a dipstick. So it's also serial dipsticks when you're doing urine alkalization. The dosage of sodium bicarbonate that you're giving at that particular point is usually 1 to 2 millimoles per kg, and then you infuse it. But then remember, it's contraindicated in volume or fluid overload and hypokalemia. The complications of it, as I mentioned earlier, are that, yeah? The last, or at least the second last method of enhanced elimination is hemodialysis. And I'll start this by asking a question. So hemodialysis is least likely to be useful in which of the following toxicity? Remember, the pharmacokinetics and the chemical properties of the toxin helps us determine whether enhanced elimination will occur or not. So I'll also just go ahead and answer this for you just because of time. The answer to this is D, which is systemic ion toxicity. and just like the initial one, there's a mnemonic that tells you which toxin can benefit from enhanced elimination. And the mnemonic is COP, I've stumbled. COP is COP, AV is IVE, and stumble is stumbled. So carbamazepine, in case you have a higher or smaller gap, so in your paracetamol, in your salicylate toxicity, all the toxicities are called a higher or smaller gap. Propylene glycol, isopropanolol, valproic acid, when you have an acid excess, so when you have a metabolic acidosis, irrespective of whatever toxin it is, but when you have a metabolic acidosis, dialysis will help you sort out that metabolic acidosis. Salicylase, theophylline also falls in here. If you have a uremia because of a neurotoxic drug, methanol, barbiturates, lithium, ethylene glycol, and diethylene glycol. So they're a bunch, but yeah, that mnemonic could help you. But I think it is also important for you to just refer to this information. So dialysis essentially is the extracorporeal elimination that we're talking about, and there are two modalities. Can be CRRT, which is a much longer duration dialysis that takes quite a little amount of toxin out per unit time, but then it is good for hemodynamically unstable patient, while hemodialysis takes a lot of blood from your body and therefore takes a lot of toxin out at the same time, but for hemodynamically unstable patients, it may not be exactly the same thing. Now, there are other factors of the toxin that help us determine which modality to use, but I'll not belabor the point. But of course, they're noted in the slide over here. So for example, for CRRT, for your hemodynamically unstable patient, or a toxin that has a high protein and tissue binding capacity, which means it has already distributed into the blood or into the tissue, sorry, and then you need to get it out slowly, or organic or substances with very long half-lives, and substances that are prone to rebound phenomena. Remember, for a lot of these toxins that you dialyze, there can be rebound phenomena. So, and one of them is, for example, methanol. You can dialyze methanol and then 36 hours later, which is approximately the amount of time it takes for the rebound phenomena to occur, the patient gets methanol poisoning again. This is because the methanol has a large volume of distribution. And so what you removed was what was intravascular. And then once you stop dialyzing, whatever was extravascular in the tissue comes back into the tissue, and then you have some more poisoning. So you need to talk to a nephrologist about this or a toxicologist about this, okay? Now, exchange transfusion, as I mentioned earlier, is very specific for hemoglobinemia, but this can be done in probably critical setups. Now, the reason why I'm mentioning all this is so that you need to know. So say you are somewhere in northeastern Kenya or in Lamu, and you have a patient. You need to understand, one, that you have fully resuscitated the patient. So you've done your air breathing circulation. Two, you've done your risk assessment and understood what level of care this patient needs. And three, hopefully by this particular point, you have, following the toxidromes and taking the history, you found out probably what exactly is happening in this patient, and you know what would be the definitive care. So for example, if a patient has a very severe acidosis and you're in Lamu and you can be able to fly them to, say, Nairobi, or a place where they can get dialysis, or maybe you're referring them one way or the other because you don't have the facilities to take care of this patient, it's important that you transport them to a place that has the facilities that you need to sort out this. So you cannot send them to the next referral facility, yet you know the next referral facility does not have a ventilator, or the next referral facility does not have a dialysis machine. This is what the patient requires. So that was essentially the purpose of going through all these enhanced elimination techniques. They're not things that you will probably or regularly do in the ED. They'll be probably done in the ward or in critical care, but it's important that you know. And secondly, in case you have, say, delayed transfer of a patient, some of these things can be started early in the ED. So for example, some EDs can start dialysis. I know some emergency departments in Kenya can start dialysis. So if you're able to, you probably just need to continue. So Jean, we're not going to belabor the point regarding antidotes. We have tried to give them quite a low significance. Not to say they're not important in managing these patients. They are quite important and they're miraculous drugs. But for the case of this, for the sake of this presentation, I'd like us to really emphasize on a systematic approach to managing these patients and keeping these patients alive in the first place, for us to have the opportunity to give an antidote. So that's their role. It's a secondary role, a secondary supportive care and secondary resuscitation. And the usual indications for giving an antidote. Remember, antidotes are also medication and they have side effects. So the indications are, for example, toxin, when the toxin that is in the body is likely to cause more harm than giving the antidote. That is just an obvious reason. When management by standard resuscitation procedures is producing insufficient outcomes, or when there's failed decontamination, or if the antidote is available. If you have the antidote, don't deny the patient the antidote. But remember the first three components of the indications of antidotes. Yeah, the risk has to be less than the benefit. Some of the antidotes that we mentioned earlier are still here. Remember your calcium channel blockers poisoning. You can use calcium. You can use, and this is quite a favorite for me because children, especially children to parents who are hypertensive and have calcium channel blockers lying around, tend to just take them and swallow them. Calcium channel blockers, by the way, they don't taste really bad. I know this because I've tried chewing one, and so that's why children will probably take a lot of them. So remember your glucagon, your insulin, and your calcium. Just looking at that list, I think this is information that can be easily found in our protocols. So remember about occupational toxins. We talked about things that happen, for example, in the hospital. Emphasis is put on prevention, but then in case it happens, you remember you need to irrigate. Now, you can irrigate between 15 and 30 minutes, but the longer the better, but taking into consideration the patient's symptoms and the tolerance to irrigation. So I'd like just to mention a case here for a 39-year-old who's brought to the hospital drowsy at night. Now, this is an interesting case. 39-year-old female brought to the hospital drowsy at night and is afebrile with localized limb twitching. Yeah, the pupils are reactive, RBS is normal, and the other vitals, at least the ones that you're given, also seem normal. So I'd just like you to note the night out part. What do you think the answer is?
Might have been drugged.
Yes. That is what I was trying to go for, and this is quite a common question, and this is something that we receive in the emergency departments quite a lot.
And I think somebody actually asked in the chat.
Yes, yeah.
Kenneth, yeah, various types of mchele. I think we've all heard about people being drugged in the club or while they're out, their drinks being spiked.
Yeah, I'm still gonna lay emphasis here on like occupational exposure, on prevention. So make sure you're hanging out with the right people and the right places in managing this. But yes, dates or rape drugs are quite common nowadays, and unfortunately, yes, these are the types of mchele. Alcohol itself is a mchele because alcohol itself makes you make questionable decisions and it impairs you to some extent. So for some of these patients, you might think that something was added onto their drink, but maybe they just had too much to drink. So I want us to almost always put in our head that alcohol is one of the drugs that can be used as a date rape drug. But the other one is ketamine, which causes dissociative sedation, but it's very difficult to find. But the most common one is the last one, that it is gamma hydroxybutyric acid. Gamma hydroxybutyric acid comes by many names. It's called, some people call it liquid Fanta, and it has the opposite effects as amphetamines. I remember the toxidrome that amphetamines caused, which was essentially the hype guy. So this one will cause CNS depression, but the key thing to this is that it can reverse quite rapidly. So this is the type of patient who will be in emergency department with CNS depression, but then you walk out and you come back in and you find like the GCS is going up and going up quite fast. Consider gamma hydroxybutyric acid. The reason why is because it's a precursor to a GABA neurotransmitter, and so it is turned into GABA quite fast and then broken down quite fast. But then that does not mean that it cannot cause quite serious outcomes, because if the CNS depression is significant enough, you might lose the basic functions. So yeah, but the interesting thing about it is that, you know, it is metabolized, this gamma hydroxybutyric acid is metabolized by alcohol dehydrogenase. And so when they are co-ingested, yeah, it essentially prolongs the symptoms. Yeah, when you co-ingest them with alcohol, it prolongs the system, so the symptoms. So that's something that you need to note. Snake bites are also a type of poisoning, but you know, these are envenomations that are quite obvious, and the patients will know exactly what happened. Now, you will not be able to tell what snake has bitten the patient, but yeah, you follow the systematic approach, of course, and the antidote over here is, of course, antivenom. But it's important to note the pathophysiology of both of them. You know, there's cytotoxic snakes, there's neurotoxicness and neurotoxic snakes, and they present in different modalities. But I will not belabor the point. Remember that in our country, you can get antivenom from anywhere that keeps snakes. So if you go to a museum or a park or whatever, any place that keeps snakes, they probably have antivenom. So that is the place that you need to go to get it. So Jean, because of time, I think we are over time by a few minutes. I'd just like us to go through a summary for this presentation and to emphasize the point that we're trying to make. And please, if you have any questions, this is the time. We'll have a few minutes after this. Now, the point you try to make here, and the point of all this, is to understand that poisoning, it is futile to master every individual poison and master its management. So you need to take a systematic approach on both diagnostic and management of the patient. So because it's some classes of substances cause specific presentations, they're also managed probably in the same way. And this hence brings in the concepts of toxidromes. In acute poisoning, you need to consider decontamination. That is external decontamination, and this is essentially the gospel of this presentation. You need to remove the risk of...
but keep yourself safe first.
Yes. You need to keep yourself first and remove the risk of both the patient and you getting more exposure from that particular poison. That will be, if you do that, you've essentially done 25% of the work. And then the other part of the work is ensuring that you resuscitate this patient. And it is the simple resuscitation, airway, breathing, circulation, with caveats of modification being that in the event of poisoning, you can prolong CPR for a longer duration of time. And two, you could start life support earlier. So this is a patient who your threshold for intubation will be lower, your threshold for, inotropes would even be lower. But yeah, then the other set of points that you need to understand, maybe Jean, you can mention them to us.
Yeah, so always risk stratify your patient. Try and get a quick sample history that helps you know the events around what they might have took, how much they might have taken, and also in terms of your clinical presentation, how sick is your patient? Yeah, we don't give everybody who's ingested pesticides atropine, right? So risk stratify your patient accordingly. Act fast to try and help slow down further absorption of whatever they've taken. And then always remember it's a multidisciplinary approach because some of these ingestions are intentional. So you might need to loop in your psychologists, your counselors into the management as well.
Yes. The last point is specifically important because this is a point that is forgotten most of the time. It is not uncommon for patients to be discharged from hospital because of, for example, intentional exposure to something without getting psychosocial support. And then this is the type of patients who essentially are repeat visitors because they definitely come back because of attempting suicide or at least achieving it this time. So with that, I think we come to the end of our presentation, unless there are any questions.
So I think we can try in the few minutes that we have, we can try and attempt to answer some of the questions in the Q&A box first. So the first question, how do you go about a phenytoin reaction? So somebody had a patient, they gave some phenytoin, and then they developed rashes and GCS dropped. Okay, so Evan, do you want to give it a go?
Yes. So I wish somebody else answered this question because it's essentially what I wish we could ask somebody to answer it so that we can see if we know it. But yes, a patient who came in, GCS 13 out of 15, which is a little bit low, with a phenytoin reaction, at least the substance that causes this is known. So this essentially makes our risk classification and definitive diagnosis quite easy. But then I would, one, try to decontaminate the patient. So that is the first point. So, and decontamination can be, as easy as, or maybe there's still some pills, or not pills. I mean, maybe there's still some drug running in the patient. So, you need to stop that to prevent further exposure. And then the second thing you need to do is do your resuscitation. So you need to do your airway breathing circulation. Now, somebody asked in the chat earlier about what is serial GCS. Now, this is where serial GCS comes in. This is exactly what serial GCS means. You need to check the Glasgow Coma scale of your patient serially, because the GCS can drop according as noted in this question. GCS can drop from 15. Sorry, I've lost the question. Where did the question go? GCS can drop from.
GCS dropped from 13 to 5.
Yeah, the GCS can grow from 13 to 5 quite fast. And therefore, you need to be there with your intubation set, your crash cut, and everything that you need. You need to update your ICU. You need to inform your ICU. You need to inform your primary teams, that is your toxicologists and all that. So for the purposes of this discussion, so how do we go about, I think the question is, how do we go about this phenytoin reaction? One, is it an anaphylactic reaction in which, of course, we'll give our epinephrine, right? And that is the definitive management. But the supportive management, which contributes to the prognosis of the patient, is your airway, breathing, your decontamination, airway, breathing, circulation, and disability, right? And also remember your hypothermia, remember your hypoglycemia, remember your cardiac arrhythmias and all that. All right, I hope that answers the question.
Yeah, so basically that was an allergic reaction, but yeah, you need to still do your ABCs, stop whatever is the offending agent. And also remember, phenytoin is a notorious drug that can cause SGS as well. Okay, so now the next question, if a patient is already vomiting, are antiemetics indicated? So actually, yes, they are, because with someone vomiting uncontrollably, their airway is at risk, yeah? And one of the first things we deal with is airway. So you want to make sure the airway is okay. If you have an antidote, you can give the antidote to stop all the secretions and stuff. Yeah. Okay.
Yeah. I just to add on that, look, but my question would be, what is the mentation of the patient? So is your patient, GCS 15 over 15 alert and vomiting? In which case, yes, you can give your antiemetic. But is your patient GCS 12 over 15, for example, in a toxidrome that essentially involves copious secretions and stuff like that, which you mentioned, the cholinergic toxidrome, is the offending substance that causes the toxidrome still there, and is it going to cause further vomiting and further secretion? So if as soon as you answer that question, you'll know, is this a patient who I need to have a definitive airway and support breathing, airway and breathing, or is this a patient who I need to give antiemetic? So it is two-tiered. It really depends on how the patient presents, and that is what will determine how you'll manage your emesis. Okay.
Okay. How do you manage cocaine overdose through intranasal abuse?
Yes. So cocaine overdose through your intranasal abuse is managed like cocaine overdose through any other form of abuse. I do not know if maybe this question was trying to lead me towards thinking decontamination or the early decontamination phase of it. In which case, remember that you can wipe off, some of the powder or whatever it is that the toxins that are on the patient's skin, and that would be the first thing. and then progressively you manage it supportively. All right?
Yep, and remember it's a sympathomimetic, yeah? So just go down the same path. Supportive care is very important. Okay. Someone else asks, in a patient who's taken OPP but doesn't have secretions, the chest is clear, is atropine indicated?
So a patient who has taken organophosphate poisoning, the chest is clear. Look at your secretions. I think that is the important part. The chest could be clear, but the oropharynx could have copious secretions. So secretions anywhere, you need to give atropine. But yes, of course, if there are secretions to the extent that you're having crepitations in the chest, then that actually even emphasizes the fact that it is not really just about your antidote, which is atropine, but supportive care. So this is the patient who you need to have a definitive airway put on the ventilator as early as possible. Okay.
Then kindly comment on gastric lavage.
A beautiful question. And it's surprising that we did not talk about it on the presentation. I think it was a big oversight from our part. Now, gastric lavage is contraindicated for everyone and everything in the emergency department. So just do not try to forcefully pump things out of people. I think that is the short answer to it.
Yep, good. So do not do gastric lavage. Okay, you'll do more harm than good. Okay. So there's a question on methanol poisoning. If your patient has methanol poisoning and is comatose, and you have high percentage alcohol, do you give it straight IV from the bottle? I'll take this one. In our protocols, there is actually a way to give IV ethanol that you dilute it in some dextrose fluid, and you can give it safely IV as well. Okay. Then there is another question about, lots of people are requesting for the notes. The notes, the presentation will be available on the Daktari Online platform. And I think as well, this recording will be on the EMKF YouTube page. So if you want to refer again, that's a good place to go get the notes.
So somebody, Dorcas is asking quite a nice question here, that at what point in aspirin overdose do you start urine alkalinization? So we'll just go to urine alkalinization. Now, you are much safer starting to alkalinize your urine when you've risk stratified and you've noticed that your doses are beyond therapeutic doses. So when you have a toxic dose of aspirin, you need to start urine alkalization. I think that's the simple answer to it. All right. Okay. And those are the doses of sodium bicarb that you give for that. And remember, phenobarbital is also an indication for urine alkalization. Grace is asking what are the indications of prolonged resuscitation in patients post-poisoning? Now, for patients who have been poisoned, that in itself is an indication for prolonging your resuscitation, just to give you enough time to give the antidote and to institute supportive measures. Of course, this is within limit, because if your patient is diseased, your patient is diseased, and there's nothing much you can do about it. Okay? So your constant reassessments are quite important in this setting. Okay.
Okay. Good.
Hassan is asking what is a date rape drug. This is essentially the type of drugs that you find patients having, patients who have been sexually assaulted, and it happens mostly in the setting of recreational use and drugs of abuse. So always remember butyric acid and your ethanol and your ketamine that are quite significantly used. And for these patients, consider the chance that they might also have been raped, which might have been successful, sadly so, and therefore you also need to take care of them in that perspective. And maybe we'll have a series one day about rape and management of rape victims.